So good morning, everyone, and welcome to the February 2018 ACIP meeting. It is my great honor to use the Stanley Plotkin gavel to open this meeting. We need one of those things. We need a So welcome to the meeting. We have a very full agenda for the next 2 days. We're very happy that you were able to join us. And with that, I will turn it over to Amanda to get us going.
Good morning, everyone. 1 second. Good morning and welcome to the February 2018 ACIP meeting. Next slide. The proceedings of this meeting are accessible to people not in attendance via the World Wide Web. Welcome to those of you who are not attending the meeting in person. We have Stephanie Thomas, who's sitting over here, and Natalie Green, who is likely still outside, who are assisting us for the duration of this ACIP meeting to assist with meeting functions. So if you need anything, please find one of them. Handouts of the slides to be presented have been distributed to the voting ACIP members and are available for members of the public on the table outside the auditorium. Additionally, slides are available on the SharePoint site for our liaison and ex officio members. Next slide. I just wanted to let you guys know where you can get food and coffee. If you take the elevator down to the basement level, there's a CDC cafeteria that visitors without an escort, and there's coffee and food available there. You're also welcome to go across the street and just be careful about timing in terms of getting back in through security before lunch. Next slide. Slides presented at this meeting will be posted on the ACIP website approximately 3 to 4 weeks after the meeting. The live webcast videos will be posted approximately 4 weeks. The meeting minutes are posted on the ACIP website generally within 90 days of the meeting. The minutes from the October 2017 meeting will be available in the next week or two. Next slide. The next ACIP meeting will be convened at CDC on Wednesday and Thursday, June 20th and 21st, 2018. Registration for all meeting attendees is required and will be open this Friday on the ACIP website. The registration deadline for non-U.S. citizens is May 16th, 2018, and for U.S. citizens, registration closes June 11th. Registration is not required for webcast viewing. I am going to hand it over to Dr. Bennett to introduce some guests.
Thank you, Amanda. Next slide. Do we have a slide? We wanted to welcome some special guests to this meeting. First, Dr. Alejandro Craviado, who's chair of the World Health Organization's Strategic Advisory Group of Experts on Immunization, better known as SAGE. We'd also like to welcome Dr. John Abramson, chair of the Vaccine Investment Strategy Steering Group. And I believe John was the chair of the ACIP at the time that I began coming to the ACIP. So it's a special pleasure to welcome him, and there he is. Dr. Kuzunori Oishii, Director of Infectious Disease Surveillance Center at the National Institute of Infectious Diseases. I'm not sure where he is. Over there? Welcome. And finally, we have students from the University of Alabama School of Public Health. And I don't think they've arrived yet. Next slide, please. In terms of ex officio and liaison representatives, Dr. Melinda Wharton, Acting Director of the National Vaccine Program Office, will be serving as the ex officio member. We'd also like to welcome the American Immunization Registry Association, or ARA, as a new liaison organization. Rebecca Coyle, who I think many of you know, the executive director, will be serving as the liaison, and we look forward to input from ARA. Obviously, they are a very critical implementation partner, so we're very happy to have them join us. Next slide. We have 2 new voting ACIP members who will be serving terms through June of 2021. 21, yes. First of all, Dr. Hank Bernstein is a board-certified pediatrician and professor of pediatrics at Zucker School of Medicine at Hofstra Northwell, so at the Cohen Children's Medical Center. Dr. Bernstein is also editor of the AAP's Red Book Online. Welcome, Dr. Bernstein. We're so glad you joined us. Second, Dr. Sharon Fry is board certified in internal medicine and infectious diseases and holds the Ralph Kinsella Endowed Chair in Internal Medicine at St. Louis University School of Medicine. She's clinical director of St. Louis University's Center for Vaccine Development and serves as the director of the Vaccine and Treatment Evaluation Unit. Welcome, Dr. Fry. We look forward to having these new members. They have tremendous experience and insight, and we're really glad that they were able to join us. Could I have the next slide, please? Additionally, we are pleased that Cynthia Pellegrini has agreed to extend her term through June of 2018. We're so grateful for her perspective and insight. I think it's fair to say that Cindy has really figured out how best to represent many consumers, their voices to the table, and we are so appreciative of that. And now back to Amanda.
We have several member substitutions for liaison and ex officios at this meeting listed here. Next slide. Topics presented at ACIP meetings include open discussion with time reserved for public comment. Public comment period is scheduled immediately preceding each ACIP vote and at the end of the meeting day. We ask that public comments prior to a vote be related specifically to the vote being taken for that vaccine, and comments not related to a vote be held until the public comment period at the end of the day. People who plan to make public comments should visit the registration table at the rear of the auditorium and complete the public comment form and leave it on the table. We'll collect these and log you in for public comment. Ms. Stephanie Thomas will record your name and provide information on the process. People who make public comments should provide 3 pieces of information: your name, organization, if applicable, and any conflicts of interest. Registration for public comment was also solicited in advance of this meeting through the Federal Registry. Given time constraints, each individual is asked to limit their total comments to under 3 minutes. Comments not presented at this meeting may be substituted in writing for inclusion in the meeting minutes. Because of the size of this meeting, of this agenda, we'll only be taking comment from the audience during the public comment period at this meeting. We'll be taking questions and comments from the voting members and the liaison and ex officio members during the discussion prior to the public comment. Next slide. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct clinical vaccine trials or serve on data safety monitoring boards may present to the committee on matters related to these vaccines, but these members are prohibited from participating in committee votes on issues related to these vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines from that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. We will be using electronic voting again at this ACIP meeting. ACIP members will vote simultaneously. Results will be displayed on the screen when voting is closed. We will then verbally verify votes around the table, and ACIP members can add a comment related to their vote if they choose. Next slide. Oh, can you go back one slide? I apologize. Wrong title slide, but the right slide. Sorry about that. This slide shows the ACIP website where detailed instructions for the submissions of names for potential candidates to serve as ACIP members may be found. Applications for ACIP membership are due no later than August 1st, 2018, and this is for a 4-year term beginning July 2019. 2 slides. We'll now request that all cell phones please be turned off to avoid disruption, and we will take roll call. And members, please indicate if you're present and disclose any conflicts of interest.
Thank you, Dr. Cohn. Could you start, Dr. Romero?
Jose Romero, no conflicts is disclosed.
Peter Szilagyi, no conflicts.
Cindy Pellegrini, no conflicts.
Paul Hunter, no conflicts.
Sharon Fry, contract from the NIH through the DMID, and on the board of, not a board, sorry, yes I am. I was board for Bavarian Nordic within the last year.
Robert Atmar, no conflicts.
Grace Lee, no conflicts.
Ed Belongia, no conflicts.
Kelly Moore, no conflicts.
Hank Bernstein, no conflicts.
Chip Walter, no conflicts.
Laura Riley, no conflicts.
David Stevens, no conflicts.
And Dr. Ezianoli will not be attending this meeting, and Nana Bennett, no conflicts. Thank you. Could we now go around and have the ex officio and liaison members introduce themselves? Thank you.
Melinda Wharton, Acting Director, National Vaccine Program Office.
Barbara Moloch, National Institute of Allergy and Infectious Diseases, National Institutes of Health.
Nora Nair with HRSA and Vaccine Injury Compensation Program.
Wellington Sun, Division of Vaccines at CBER, FDA.
Eric Duzing, Department of Defense.
Jane Kim, Department of Veterans Affairs.
David Weber, Society for Healthcare Epidemiology of America.
Amy Middleman, Society for Adolescent Health and Medicine.
Sean O'Leary, Pediatric Infectious Diseases Society.
Pat Whitley-Williams, National Medical Association.
Corey Robertson, Pharmaceutical Research and Manufacturers of America.
Patsy Stinchfield, National Association of Pediatric Nurse Practitioners.
Caroline Quash, National Advisory Committee on Immunization, Canada.
Matt Zahn, National Association of County and City Health Officials.
Bill Schaffner, National Foundation for Infectious Diseases.
Kathy Newsel, the Infectious Diseases Society of America.
Chris Hahn, State Epidemiologist of Idaho, representing CSTE, Council of State and Territorial Epidemiologists.
Amy Walker, Biotechnology Innovation Organization.
Nate Smith, State Health Officer for Arkansas, representing Association of State and Territorial Health Officials.
Stan Grog, American Osteopathic Association.
Steve Foster, American Pharmacists Association.
Chris Finley, Association of Immunization Managers.
Chad Riddle, American Nurses Association.
Good morning, Rebecca Coyle. I'm with the American Immunization Registry Association.
Mark Natoski, America's Health Insurance Plans.
Ken Schmader, American Geriatric Society.
Sandra Freihofer, American College of Physicians. Sandra Freihofer, American Medical Association.
Kevin Alt, American College of Obstetricians and Gynecologists.
Carol Hayes, American College of Nurse Midwives.
Susan Even, American College Health Association.
Marie-Michelle Léger, American Academy of Physician Assistants.
David Kimberlin, American Academy of Pediatrics, Red Book.
Mike Grady, American Academy of Pediatrics, Committee on Infectious Disease.
Pamela Rockwell, American Academy of Family Physicians.
Thank you, and welcome to all. Having finished our administrative responsibilities, I think we'll turn on to hepatitis and Dr. Romero.
Good morning. So the terms of reference for the topics presented today by the hepatitis work group spokespersons will be for hepatitis A, the update on hepatitis A recommendations, which will update the publication by the ACIP, and the routine recommendation for hepatitis A vaccine published in the MMWR on May of 2006. We'll also talk about the use of hepatitis A vaccine for post-exposure prophylaxis among adults greater than 40 years. This is an update to prevention of hepatitis A after exposure to hepatitis A virus and international travelers. Was published in the MMWR in 2007. Regarding hepatitis B, there will be new ACIP recommendations for Heplisav-B, which was FDA licensed in November 9th of 2017, and will be a policy note on top of the document listed here for prevention of hepatitis B infection in the United States, recommendations by the ACIP published in 2018, January, in the MMWR. The workgroup considerations between November 17th and November 2017 and February 2018 are listed on this slide. So for hepatitis A, the workgroup considered risk factors for hepatitis A virus infection, specifically for HIV and immunocompromised individuals. The workgroup had discussions regarding a review of homelessness as a risk factor for hepatitis A, and then a review of hepatitis A post-exposure prophylaxis and international travel draft policy document was discussed. With regards to hepatitis B, grade for Heplisav B was discussed. Length, considerations for Heplisav B, and proposed recommendations were also discussed. And then a policy note for the recommendations of the Advisory Committee on Immunization Practices for the use of hepatitis B vaccine with a novel adjuvant. At today's session, we will discuss grade for Heplisav B. We will also discuss considerations and proposed recommendations, and this will be followed by a vote. For hepatitis A post-exposure prophylaxis grade will be discussed. Hepatitis A post-exposure prophylaxis and international travel considerations and proposed recommendations will be discussed also, and then this will be followed by a vote. The next steps for the group will be to present the full updated hepatitis A vaccine statement for a vote. This will be in future meetings. And then to continue deliberations on the adult hepatitis B vaccination. The workgroup members are listed on this slide. The ACIP members are listed individually, liaison members, ex officio members, consultants, and of course our lead, Noelle Nelson, who carried a lot of this work on her shoulders. Additional acknowledgements are here, members of the Division of Viral Hepatitis, Immunization Services Division, and then the ACIP Hepatitis Work Group from the CDC. I will now turn this over to Shelley, I think. Thank you.
Good morning. Today I'll present results of our grading of recommendations, assessment, development, and evaluation for the new Heplisav B vaccine. This slide describes the grade process. For our analysis, we developed the policy question, considered critical outcomes, reviewed and summarized evidence of benefits and harms, evaluated the quality of evidence. In addition, we reviewed the limited health economic data, and we will have a non-preferential recommendation and summarize the grade category. Our policy question was, should Heplisav B vaccine be recommended for adults on a 2-dose schedule over 1 month? To grade the evidence, we utilized the PICO format. The population was adults 18 years and older. The intervention was Heplisav B administered in 2 doses over 1 month. The comparison included existing licensed hepatitis B vaccines for adults in the US. While we included all licensed vaccines in our search only yielded Engerix B comparative studies. The outcomes we evaluated were hepatitis B infection, mild adverse events, serious adverse events, and cardiovascular safety. The slide here lists outcome measures included in the evidence profile. We determined the outcome of preventing hepatitis B infection as of critical importance. Regarding harms, we reviewed mild adverse events as important and serious adverse events and cardiovascular events as critical. We performed a systematic review of Medline, Ovid, CAB abstracts, Embase, Global Health, Ovid Scopus, and Cochrane reviews. Our search terms are listed here. Articles were included if they presented immunogenicity or disease endpoints or safety data on Heplisav. Articles were excluded if subjects were non-human primates, or basic science, secondary data analyses, immunogenicity outcomes for non-licensed formulations or use of HEPLISAV, general review or opinion perspectives, or if we were unable to abstract the data. Our search yielded 141 abstracts. 70 duplicates were excluded. 71 unique abstracts were reviewed. 35 of those were excluded due to relevance. 36 full articles were reviewed, and 31 of those were excluded because not primary data, not population of interest, or we could not abstract the data. There was one additional article published after we conducted our search that was included. So in summary, our search strategy yielded 6 articles that were included for grade. This slide summarizes the standardized initial evidence types by study design for grade. The next series of slides will summarize the grade of evidence for HEPLISAV-B benefits. The table summarizes the characteristics of included studies for outcome number 1, hepatitis B infection in grade. To orient you to the table, the columns represent the publication, the study type, population, intervention, comparison, main outcome, funding, and site. There were no studies that looked at hepatitis B infection as an outcome, so we used immunogenicity as a surrogate outcome. More specifically, the seroprotection rate, or SPR, which was defined as antibody to hepatitis B surface antigen, or anti-HBs, greater than or equal to 10 MIU per ml after vaccine series completion, which was usually 24 to 28 weeks after receipt of the first dose. Of note, HEPLISAV was administered at 0 and week 8 for Halperin 2006, and HEPLISAV was administered at 0 and week 4 for the other studies. The seroprotection rate after vaccine series completion are summarized on this slide. For HEPLISAV, the SPR ranged from 90 to 100% versus 70 to 90% in the comparison group, with a number needed to vaccinate between 5 and 10. The table summarizes the type of evidence for hepatitis B infection as an outcome. The initial evidence level was 1 because all 4 studies were random clinical trials. There were no serious concerns for risk of bias, inconsistency, or imprecision. However, there were serious concerns for indirectness. There were no studies that looked at hepatitis B infection as an outcome and used immunogenicity data only. For Halperin 2006, the intervention was HEPLISAV series at 0 and 8 weeks, which is not the licensed series. Other considerations were that all studies were funded by Dynavax Technologies Corporation. As a result, we downgraded the evidence type from 1 to 2. The next series of slides will summarize the grade of evidence for HEPLISAV-B harms. The next 2 slides summarize the characteristics of 6 included studies that reported adverse events. The 4 studies listed on this slide were all random clinical trials. Sablon 2012 was not included in the benefits grade because it used a non-licensed 3-dose series of HEPLISAV. They all reported mild and serious adverse events, but cardiovascular events were only reported in Hayward 2013. This slide includes 2 additional randomized clinical trials that reported mild and serious adverse events as well as cardiovascular events. Of note, HBV23 is not yet published. Janssen 2013 was not included in benefits grade because it used a 3-dose series for HEPLISAV. This table summarizes in aggregate any mild adverse events, injection site reactions, and systemic reactions for all studies included. A similar proportion of mild adverse events were reported in HEPLISAV compared to Engerix, 45.6% versus 45.7%. There was a higher proportion reporting injection site reactions in HEPLISAV compared to Engerix B, 35.5% versus 30.8%. The majority of these were arm redness and soreness. There were fewer systemic reactions reported in HEPLISAV compared to Engerix, 28.1% versus 30.1%. This slide summarizes serious adverse events for 6 studies included. 4 studies reported serious adverse events considered related to vaccine. Reported serious adverse events were similar between Heplisav and the comparison groups. One related serious adverse event in Heplisav group was an individual with progression of chronic kidney disease stage 4 to end-stage renal disease 28 days after receiving dose 1. And one related serious adverse event in the Engerix B group was an individual that developed reactive airway disease due to Churg-Strauss syndrome and ANCA-positive vasculitis 42 days after receiving dose 3. This slide summarizes the reported cardiovascular events in 3 studies in aggregate. Authors note that subjects with cardiovascular adverse events had more than one cardiovascular disease risk factor. There were more cardiovascular events reported in Heplisav recipients compared to Engerix B, but this was not statistically significant. For the type of evidence for adverse event outcomes, there were no serious concerns for risk of bias, inconsistency, indirectness, or imprecision. However, other considerations are that all studies were funded by Dynavax Technologies Corporation and adverse events from HBV23 is unpublished. Nonetheless, the evidence type was the highest level, 1, for all studies. The table here summarizes the characteristics of 3 studies we decided to exclude from grade. Halperin 2012 was excluded because we were unable to abstract safety data as it was only presented in a figure, and there was no comparison group. Halperin 2013 was excluded because we were unable to abstract safety data, and recipients received both Engerix B and Heplisav, but only 1 dose of Heplisav. Janssen 2015 was excluded because it was a subgroup analysis of data from Janssen 2013, and the data of the main study were already included in our grade. The analysis had certain limitations. All data are from the same funding source, Dynavax Technologies Corporation. The generalizability may be limited because 21% of patients in 3 of 6 studies were not in the United States. 18% of patients in 2 studies were from Canada and Germany, which may be similar to the US population, and 3% of patients were from 1 study in Korea, Philippines, and Singapore, which may differ. All data is from clinical trials, and no real-world data exist. Studies have not looked at disease endpoints like hepatitis B infection. Cardiovascular events were not reported in all studies, and no long-term data published on immunogenicity and adverse events exist. The table summarizes grade of Heplisav B compared to licensed hepatitis B vaccine, Engerix B. Beneficial outcomes included were hepatitis B infection, which was downgraded from 1 to 2 due to indirectness with the use of the seroprotection rate as a surrogate for protection. Regarding harmful outcomes, mild and serious adverse events reported showed no difference detected between Heplisav and comparison populations with an evidence type of 1. While more cardiovascular events were reported in Heplisav recipients compared to Engerix B, this was not statistically significant, and the evidence type was 1. Information gaps are highlighted on this slide. There was indirectness since there was no study looking at hepatitis B infection as an outcome. No real-world cohort data exists. Long-term protective immunity is unknown. There was 1 industry-funded cost-effectiveness analysis that showed Heplisav B use had an incremental cost-effectiveness ratio, or ICER, less than $25,000 per quality-adjusted life year compared to Engerix B for diabetic patients, patients with chronic kidney disease, patients with end-stage renal disease, healthcare workers, and travelers. But more populations are needed in future cost studies. Post-licensure studies will be included in future workgroup considerations. I want to acknowledge Dr. Ruth Link Gels for all her hard work in helping me put together these grade tables. Thank you.
Thank you for that excellent summary. Questions for Dr. Harris? Yes, Dr. Belanger.
Thank you. Can you just clarify what was the risk window for cardiovascular events?
I'll defer to the manufacturer for that.
Good morning. I'm Dr. Randy Heyer from Dynavax. The risk window varied for the length of follow-up. In the HBV 16 and 23 phase 3 studies, it was 13 months following dosing of Heplisav. Thank you.
Thank you. Other questions? Is there a motion? All right, sorry, yes, the considerations. Thank you. Yeah, it's going to be a long day. Dr. Nelson. Sorry, Dr. Schilly.
Do I advance my slides? Because it's not. Good morning. Hepatitis B is an infection of the liver caused by the hepatitis B virus. It is transmitted through percutaneous or mucosal exposure to blood or body fluids. Hepatitis B virus is highly infectious and remains viable on environmental surfaces for at least 7 days. It can be transmitted in the absence of visible blood. Symptoms include anorexia, malaise, abdominal pain, nausea, vomiting, and jaundice. Extrahepatic manifestations may also occur. Acute hepatitis B infection is symptomatic in 30 to 50% of adults. The fatality rate is less than 1.5%, but is higher in older adults. Fulminant infection occurs in less than 1% of cases, but often results in death or liver failure necessitating transplantation. Chronic hepatitis B develops in 90% of persons infected during infancy and in less than 1 to 12% of persons infected as adults. Chronic infection more often develops among the immunosuppressed and persons with diabetes. Persons with chronic hepatitis B have a 15 to 25% risk for premature death from cirrhosis or liver cancer. An estimated 850,000 to 2.2 million persons are living with hepatitis B in the United States. Although the number of reported acute hepatitis B cases has declined from approximately 8,000 in the year 2000, the number of cases increased from 2014 to 2015, concomitant with the increase in injection drug use. There were 3,370 cases reported in 2015, which corresponds to an estimated 21,900 cases when considering under-ascertainment and under-reporting. The incidence of reported hepatitis B cases is highest among the 30 to 49-year-old age groups. Incidence is lowest among the 0 to 19-year-old age group as a result of routine infant vaccination that has been recommended since 1991. Hepatitis B vaccines first became available in the United States in 1981 as a plasma-derived vaccine. Recombinant vaccines became available in 1986 and have replaced plasma hepatitis B vaccines. Currently recommended hepatitis B vaccines are safe, immunogenic, and effective. Anaphylaxis occurs at a rate of 1.1 per million doses administered among yeast-sensitive individuals. Hepatitis B vaccines are generally administered as a 3-dose series, and protection lasts at least 30 years. Booster doses are not routinely recommended. Currently recommended monovalent formulations, either Injurex or Recombavax, are available for all ages. Combination formulations are available for certain age groups, as depicted on this slide. Hepatitis B vaccination is routinely recommended for all infants and children less than age 19 years. Adults recommended for hepatitis B vaccination are those at risk for infection by sexual exposure, those at risk for infection by percutaneous or mucosal exposure, international travelers to certain regions, persons with chronic liver disease, persons with HIV infection, incarcerated persons, and all persons seeking protection from hepatitis B infection. Antibody to hepatitis B surface antigen greater than or equal to 10 milli-international units per milliliter, measured 1 to 2 months after vaccine series, corresponds to vaccine-induced protection. Among healthy individuals aged less than 40 years, 30 to 55% have protective antibody levels after 1 dose, 75% after 2 doses, and greater than or equal to 90% after 3 doses. Lower 3-dose seroprotection is associated with advanced age, diabetes, renal disease dialysis, obesity, chronic illness, and smoking. Among persons with diabetes, seroprotection proportions range from about 30 to 94%, and among persons receiving dialysis, seroprotection proportions range from 10 to 84%. This slide depicts 3-dose hepatitis B vaccine coverage for subgroups of adults for whom vaccination is recommended. Coverage ranges from 12 to 26% for persons with diabetes to 61.4% for healthcare personnel. Among adult vaccine safety data link enrollees, roughly 40 to 60% completed the hepatitis B series within 1 year of initiation, while fewer than 5% completed the series between 1 to 2 years and greater than 2 years after initiation. 15 to 26% received only 1 dose, while 13 to 21% received 2 doses. I will now discuss Heplisab-B. Heplisab-B was licensed by the FDA on November 9, 2017. It is indicated for active immunization against infection caused by all known subtypes of hepatitis B virus in persons aged greater than or equal to 18 years. It is administered as a series of 2 doses separated by 1 month. Heplisab-B uses the novel 1018 adjuvant consisting of immunostimulatory cytidine phosphate guanosine, or CpG, motifs, which binds toll-like receptor 9 to stimulate a directed immune response to hepatitis B surface antigen. Studies have demonstrated high rates of seroprotection with Heplisab-B. 90 to 100% of subjects receiving Heplisab-B attain seroprotective antibody levels versus 71 to 90% of subjects receiving the comparison vaccine. Among subjects with type 2 diabetes, 90% of Heplisab recipients versus 65% of comparison vaccine recipients attain seroprotective antibody levels. Among subjects with chronic kidney disease, the seroprotection proportions were 90% among subjects receiving 3 doses of Heplisab-B versus 81% among subjects receiving 4 double doses of the comparison vaccine. These graphs depict the proportion of healthy adult subjects with protective antibody levels following Heplisab-B, shown by the upper line, or the comparison vaccine, shown by the lower line. Heplisab-B recipients attained earlier and greater seroprotection than comparison recipients. By week 12 in both studies, at least 90% of Heplisab-B recipients had antibody levels of at least 10 milli-international units per milliliter. Heplisab-B has also been studied among vaccine non-responders, although sample sizes are small. Among non-responders to 3 prior doses, 53% of Heplisab-B recipients versus 38% of comparison recipients attained seroprotective antibody levels. Note that this was not statistically significant. Among non-responders to 4 to 6 prior doses, 64% of Heplisab-B recipients versus 58% of comparison recipients attained seroprotective antibody levels, and this was also not statistically significant. Among non-responders to 4 to 6 prior doses, 55% of Heplisab-B recipients versus 8% of comparison recipients attained antibody levels greater than or equal to 100 milli-international units per milliliter, which was statistically significant. The safety and reactogenicity of Heplisab-B have been assessed in clinical trials. Mild adverse reactions occurred with similar frequency among Heplisab-B and comparison recipients. Serious adverse events occurred more commonly among comparison recipients, although herpes zoster occurred more commonly among Heplisab-B recipients in one unpublished study. Cardiovascular adverse events occurred more commonly among HEPLISAV-B recipients, and potentially immune-mediated adverse events varied among studies. Safety will be further assessed through post-marketing studies. In summary, the grade was deemed to be evidence type 2 for benefits and evidence type 1 for harms. I will now discuss work group considerations. The work group discussed series interchangeability, such as when a vaccine series initiated with a hepatitis B dose from another manufacturer is completed with HEPLISAV-B, and minimum dosing intervals related to interchangeability. The work group also addressed post-vaccination serologic testing following HEPLISAV-B and revaccination for vaccine non-responders using HEPLISAV-B. ACIP recommends that when feasible, doses from the same manufacturer be used to complete the series. However, vaccination should not be deferred because a previously used manufacturer's dose is unavailable. Minimum intervals are depicted here. Doses administered at less than the minimum interval should be repeated. There are no maximum intervals. Regarding interchangeability, the work group proposes that the 2-dose series only applies when all doses in the series consist of HEPLISAV-B. When a vaccine series is initiated with 1 dose of a vaccine from a different manufacturer and must be completed with HEPLISAV-B, 3 total hepatitis B vaccine doses should be administered. Minimum intervals should be heeded. However, a series containing 2 doses of HEPLISAV-B administered at least 4 weeks apart is valid, even if the patient received a single earlier dose from another manufacturer. ACIP recommends post-vaccination serologic testing consisting of antibody to hepatitis B surface antigen for certain persons following hepatitis B vaccination. Persons with antibody less than 10 milli-international units per milliliter should be revaccinated. Revaccination can initially consist of 1 vaccine dose, followed by antibody testing, and if antibody is less than 10 milli-international units per milliliter, 2 more doses followed again by antibody testing, or 3 doses followed by antibody testing. Administration of more than 2 complete hepatitis B vaccine series, that is 6 doses, is generally not recommended, except for hemodialysis patients and other immunocompromised persons. The work group proposes that HEPLISAV-B may be used for revaccination following an initial hepatitis B vaccine series that consisted of doses of HEPLISAV-B or doses from a different manufacturer, including among healthcare personnel. Post-vaccination serologic testing and revaccination guidance remains unchanged, including administration of more than 2 complete hepatitis B vaccine series is generally not recommended. In summary of the work group's deliberations, HEPLISAV-B is likely to improve hepatitis B vaccine series completion and result in earlier protection due to the administration schedule of 2 doses over 1 month. The schedule may be especially beneficial for persons with anticipated low adherence, such as injection drug users. HEPLISAV-B will also likely result in improved immunogenicity in populations with typically poor hepatitis B vaccine response, such as the elderly, persons with diabetes, and dialysis recipients. Post-marketing surveillance studies and additional data, including safety, pertaining to the use of HEPLISAV-B will be reviewed as they become available, and recommendations can be updated prior to a preferential consideration. Future economic analyses may inform cost-effectiveness considerations of HEPLISAV-B, including its use among persons at increased risk for vaccine non-response. I would like to acknowledge those persons listed here. And then the next will be the vote.
But first, questions. Are there questions for Dr. Schilly? Yes, Dr. Walter.
Yes, and maybe you can comment or someone else. You mentioned the post-marketing safety studies. Is there any description of what those are to be?
Can you repeat that question? I'm sorry.
It's really regarding post-marketing safety surveillance and studies. What has been agreed to, or can you comment?
The FDA has worked with Dynavax on the post-marketing surveillance studies, and I will probably let either FDA or someone from Dynavax answer the questions on what the intention of those post-marketing studies entails.
Yes. There are a number of post-marketing safety studies. One which was a requirement because in the large safety trial, the study 23, a signal of acute myocardial infarction was seen, and therefore we made it a requirement for this signal to be investigated further, and it's going to be done within the context of a Kaiser Permanente non-randomized study. The other one, which is a commitment, the difference between requirement and commitment is that perhaps related to the level of concern for the safety signal. The commitment was to look at also the occurrence of zoster, because that was also seeing an increased incidence in the study 23.
Thank you. Other questions? Yes, Dr. Belanja.
Just a quick follow-up on the previous one, then I have a question. I assume there'll be a vaccine safety data link study as well looking at this. Typically there are when there are new vaccines licensed. My question, though, is related to the 1018 adjuvant, and I'm wondering, is this adjuvant used in other licensed products, either in the U.S. or elsewhere, or is it a new adjuvant?
This is the first vaccine for humans in which this adjuvant is being used.
Thank you.
Additional questions? Yes, Dr. Bernstein.
I was surprised that the hepatitis B vaccine coverage in healthcare personnel was only 60%. I could see some of the other groups. Is there an explanation for that?
Not really. We too wonder why that is so low, because there are OSHA mandates, and the institution pays for the vaccine cost, and the employers are sort of a captive audience, and that you don't have to bring them in for an appointment. But that is the 3-dose coverage. It does vary a little bit. So healthcare personnel who have direct patient care responsibilities have higher coverage than that, whereas those without direct patient care responsibilities have lower coverage, and that was sort of the average of all healthcare personnel.
Dr. Walter?
Yes, with the number of adjuvanted vaccines now available, including flu vaccine and Shingrix, is there any comment on using this vaccine at the same time with other adjuvanted vaccines?
We have no data to make a recommendation one way or the other.
So just to sort of put this in context of other vaccines, whilst preclinical studies were not done using these vaccines simultaneously, our general approach to immunizations is that they can be given at the same time in different limbs.
Dr. Hunter?
Are multiple adjuvanted vaccines used in Europe or other markets?
Dr. Ward, do you want to comment?
Not to my knowledge.
Other questions? Dr. Lee?
Could you just clarify, for certain populations where the benefit-risk balance seems very different than the average population, is this a series of steps, and the next step will be focused on those high-risk populations where the benefit-risk balance might suggest a preferential recommendation would be helpful?
That's correct. The intention now was to explore a non-preferential recommendation, and once further studies are done, including safety studies and cost-effectiveness studies, it might be appropriate at that point to consider a preferential recommendation for groups with historically poor adherence or groups with historically poor response to hepatitis B vaccine.
Yes, Dr. Riley.
Okay. Do you have any data on different race, ethnicity populations with this vaccine?
Actually, that was one of the initial comments by FDA, is that some of the early phase 3 trials did not include racially diverse groups of subjects. And as a result, the Sablin study, which Dr. Harris talked about previously, that was predominantly among Asian persons. So it's my understanding that the manufacturer addressed the FDA concerns about the lack of a diverse racial subject population.
Dr. Lee, did you have a follow-up?
Well, I was asking whether or not the guidance would have this additional information to provide guidance to clinicians in the absence of a preferential recommendation for people who seem to be at high risk for failure.
Yes, that is the intention, to note different population groups that may achieve higher seroprotection with this vaccine versus other vaccines, or populations that might have lower adherence with the other vaccines may be especially appropriate for HEPLISAV-B.
And I just want to remind you, if you're interested in making a comment from the audience, please go sign up at the public comment session table in the back. Thanks.
Okay, any further questions? Yes, Dr. Oh, I'm sorry.
Pat Whitley Williams.
Thank you.
National Medical Association. Will the post-marketing studies reflect more the diverse population in the U.S.?
I think I'll ask someone from the manufacturer to answer their intentions regarding post-marketing surveillance.
Hello, yes, hi, it's Dr. Randy Heyer again from Dynavax. Yes, the answer is we're conducting them in Kaiser Permanente, Southern California, which is quite a diverse population group. Thank you.
Dr. Missonier?
Yeah, just to follow up on something Ed Belanja said, I wonder if, Tom, somebody wants to comment on the routine post-marketing surveillance we would do in Vaccine Safety Data Link.
Hi, Tom Shimabukuro, Immunization Safety Office, CDC. So we'll be conducting VSD monitoring and also VAERS monitoring like we do for all newly licensed and recommended vaccines. We'll also explore the feasibility of conducting an epidemiologic study in the VSD to look at acute myocardial infarction.
Ms. Hayes?
Yes, Carol Hayes, American College of Nurse Midwives. I just want to remind everyone that outpatient healthcare is not regulated in this country, and so the vast majority of people that work in private offices are not vaccinated. So that 60% is probably just those that work in hospitals and institutions.
Thank you. Any further questions, comments? Dr. Romero, would you like to make a motion?
I motion that we accept, could you put the, there it is. I motion that we accept HEPLISAV-B is a hepatitis B vaccine that may be used to vaccinate persons aged 18 years and older against infection caused by all known subtypes of hepatitis, of HBV.
Is there a second? Thank you, Dr. Belanja. Further discussion? Okay, I think we'll move to public comment, and I believe that Dr. Cohn has a list, and we'll be asking people to come to the microphone.
Great, thank you. So I'm going to announce the names of the people who have signed up for public comment, and if you would please come to the microphone and speak in that order. The first is Amitha Sampith. I apologize if I'm not pronouncing your name right. The second is Bakila Davila. Ben Lee. Kate Moraris, and Larry O'Connor. Additionally, I want to let you know that Amy Shen Tang, who is a Hepatitis B Program Director with the Wayne Community Health Center, has submitted a letter. It was on the SharePoint for members to read prior to the vote, and we will have that printed and available for you guys soon. So great. Starting with Dr. Sampath.
Hi, good morning. I want to thank you for giving us the opportunity to provide public comment. My name is Amitha Sampath. I'm a physician and associate medical director at a federally qualified health center called CPAC's Cosmo. I want to provide comment on behalf of ourselves and the Atlanta Hep B United Coalition. We work to promote coalition building, education, testing, and follow-up for particularly vulnerable communities such as immigrants and refugees. I want to provide some feedback from our work that we've done, mainly that in our screening efforts, we've found that only about 21% of our target population is immune due to vaccination, and 41% were vaccine eligible. And more than half of these were in the childbearing range, 18 to 40 years old, which poses a risk for perinatal transmission. Nearly all of the population was also uninsured and below the poverty line. So for these vulnerable communities in particular, bearing the full cost of 3 doses of the vaccine, which they're often paying out of pocket for, the number of days taken off of work, and the logistics of getting to a healthcare center can pose a barrier to completing the series. So we do agree with the work group and support the new vaccine and the expedition to completion. Thank you for allowing comment.
Thank you.
Thank you. Bakila Davila?
Good morning. I'm Bakila Davila. On behalf of the National Viral Hepatitis Roundtable, a coalition of 500 plus organizations working to end the hepatitis B and C epidemics in the United States, I want to thank the Advisory Committee on Immunization Practices for the opportunity to testify today. I am here to express NVHR's strong support for the committee's recommendation of the Hep/B hepatitis vaccine. Now more than ever, we need this vaccine. An estimated 2.2 million Americans are living with hepatitis B, up to 70,000 new infections each year. This number continues to grow as a result of the opioid crisis. Reported cases of hepatitis B, which can be transmitted via injection drug use, increased 20% in the year 2015 alone. Recent data indicate that only a quarter of adults aged 19 and older are fully immunized, as adults aged approximately 25 years and older were not routinely vaccinated against hepatitis B at birth in the United States. Meanwhile, an estimated 5,000 to 6,000 Americans die each year of hepatitis B-related complications. Approval and recommendation of the Hep/B vaccine has the potential to turn the tide in the battle against the hepatitis B epidemic. Prior to the approval of this vaccine, patients had to comply with a 3-dose regimen administered over 6 months. The availability of a 2-dose vaccine administered over a 1-month period will significantly boost vaccination rates and save countless lives. This safe and effective vaccine taken over a shorter period of time could be offered not just in traditional clinical settings, but also as syringe access programs and substance treatment programs. Simply put, the widespread availability of this vaccine can slow and stop the spread of new infections and prevent thousands of deaths in this country. In sum, NVHR strongly supports recommendation of the Hep/B as a new and powerful tool in the fight to eliminate hepatitis B in the United States. Thank you.
Thank you. Next is Dr. Lee.
Sorry, I heard doctor and I got confused.
My mistake. I apologize.
I'm a student and I'm here volunteering with the Hepatitis B Foundation. Thank you for the opportunity to be here to add my voice, along with those of scientists, health experts, and advocates in support of the new science-based 2-dose hepatitis B vaccine regimen, Heplisav, as an individual living with hepatitis B. I've been receiving treatment for hepatitis B close to 4 years now, but thinking back, it amazes me how lightly I took the disease. Even after knowing I had hepatitis B, several years passed before I received treatment. As a member of the diverse lesbian, gay, bisexual, transgender community, I sought treatment because I wanted to protect myself against STDs and HIV/AIDS. I was well aware of those risks. But when I went in to seek treatment, I was told that my viral load was in the hundreds of millions. I share this anecdote just to show how little I knew and the public knows about hepatitis B, and I'm fortunate to have stumbled upon treatment, but many others may not be. The rate of hepatitis B infections in adults increased 20% in 2015 alone. In the US, at least 5,000 lives are unnecessarily lost each year from liver failure and or liver cancer. The availability of 2-dose vaccines over 1 month instead of 3 doses over 6 months is a critical tool to protect many more Americans, considering the low percentage of those who currently complete all 3 doses. And this is one less barrier for vulnerable and at-risk communities to receive the necessary protection. There's no cure to hepatitis B. Disease prevention through more effective vaccines is critical to reducing the spread of the disease and to break the cycle of infection among families and partners. I count myself among the fortunate, but I also believe that this resource-rich country, in this resource-rich country, the health of Americans shouldn't be left to chance. And through evidence-based policies, I believe we can better protect all Americans. Thank you again for this opportunity.
Thank you very much. Ms. Morales.
Thank you. My name is Kate Morales. I represent the Hepatitis B Foundation and the Hep United National Coalition. Thank you very much for this opportunity to comment. I won't repeat the statistics I already mentioned, but some additional ones that national survey data indicate that overall HBV vaccine coverage among U.S. adults is very low, 25%, and only 32.6% of adults between the ages of 19 and 49 years are fully covered by the 3-dose series. Recent studies also suggest that hepatitis B vaccine coverage is low among people with diabetes and HIV-infected individuals, 2 additional high-risk groups. It is critical to increase HPV vaccination coverage among high-risk populations and young adults born prior to 1991 when vaccination of infants became routine. Additionally, as we've seen the rise in the opioid crisis and the rise in adult and acute hepatitis B infection, the CDC National Progress Report on Hepatitis Elimination reveals that we are behind our national target to reduce acute hepatitis B infection. And a 63.8% reduction is needed to meet our 2020 goal. So a 2-dose vaccine series is critical to address this. I represent a coalition with partners in 18 states, and many of our partners have found that one of their biggest challenges is vaccine completion among highly impacted communities. One example is in 2011 to 2013, Philadelphia pilot tested a mobile hepatitis B vaccine clinic, removing the barriers of cost, language, and transportation for susceptible individuals. Even with removal of these barriers, only 13% of those who received a first dose of vaccine returned for their third dose, while completion of the second dose remained high at 81%. So we believe having the new 2-dose vaccine will play a significant role in the prevention and elimination of hepatitis B in the U.S. Thank you very much.
Thank you. And last, Mr. O'Connor.
I'm a retail pharmacist in Fort Worth that's starting a travel vaccination clinic, thanks to the inspiration for this gentleman and his partner in Publix. Patient medication adherence compliance rate are notoriously low, probably in the 20% range. If healthcare workers can't get their Hep V vaccination rates up, I'm diabetic and I've had my second but not my third shot, so I'm not self-righteous. It's probably a question for the drug reps. Are there any programs with the drug reps working with behavioral therapists to try to figure out a way, nudges or changing human behavior? Because anybody with a 3-vaccine series, if the healthcare professionals can't do it, how can the regular civilians be expected to do it? Because I think instead of going to a 2-vaccine series, it'd be just as effective to work with behavioral therapists and have programs that encourage people to finish the series rather than spending all the money on them. I mean, both are effective, but behavioral therapy is probably a lot less expensive and a little bit faster to get people to comply.
Thank you. Okay, I think unless there's any further discussion, we will take a vote on this recommendation.
I want to remind everyone to please check your voting whatever machine thing, and I don't know what it is, and check and make sure it's on channel 71 prior to voting. And voting is open? Is voting open? Yeah, voting is open now. Point it in this general direction, and we'll see how we're capturing them. There are 3 people left to vote. Remember, the last time you vote is the final one. We're looking for 14 total. Still at 11. This should not be this hard. I'm sorry, guys.
Do you want us to do it again, or?
Sharon, Laura, and Chip, please press again. We got everybody.
Got everybody? Okay, good.
I apologize, guys. We will try to figure out how to make it work the first time next time. Let's see.
Thank you very much. So the voting is completed, and it is unanimous to support this recommendation. Thank you all.
And does anybody around the table, we don't need to go around and verify our votes, but does anybody have any comments they wish to make about their vote? Dr.
Great.
Stevens?
So just a slight reservation. I think this is a huge advance and a step forward. I am concerned about that signal, that myocardial infarction signal. I am concerned about the use of this new adjuvant and certainly urge us to continue to look at the post-marketing data carefully.
Dr. Hunter?
Just a question about that. How soon would we be getting that post-marketing data update here?
Dr. Ward?
There's two kinds of data. The vaccine safety data link data will require people to be using the vaccine to develop substantive database. And Dr. Sun, do you want to comment on the post-marketing data that FDA is requiring?
We in our approval letter, which I'm looking at, it makes references to the specific dates. I think for the myocardial infarction study, we're seeing that the date or likely for completion is May 31, 2020. I also want to make one slight clarification on what I said previously. For the post-marketing studies, in addition to what I mentioned, there will also be studies looking at autoimmune diseases as well as herpes zoster, and there will be a pregnancy registry as well. So that's all included in the post-marketing surveillance.
Thank you. Okay, I think we're ready to move on to hepatitis A. Dr. Nelson?
Hello, my name is Noelle Nelson. I will be presenting on GRADE for hepatitis A vaccine for post-exposure prophylaxis in adults greater than 40 years of age. This is an overview of the GRADE process. The darker bullets are the components followed for evaluation of hepatitis A vaccine for post-exposure prophylaxis in adults greater than 40 years of age. The policy question for consideration is, should hepatitis A vaccine be recommended instead of immune globulin as post-exposure prophylaxis for prevention of hepatitis A disease in adults greater than 40 years of age? The population of interest is healthy adults greater than 40 years of age. The intervention of interest is hepatitis A vaccine administered within 14 days of exposure. We looked for studies that compared immune globulin administered within 14 days of exposure to hepatitis A vaccine. The outcomes the work group considered were hepatitis A infections, deaths, hospitalizations, adverse events, and immunogenicity. Outcome measures included in the evidence profile included 1 benefit outcome, immunogenicity, and 4 harm outcomes, hepatitis A infection, deaths, hospitalizations, and adverse events. All outcomes were determined to be of critical importance. We conducted a systematic review of data on hepatitis A vaccine in adults aged greater than 40 years, including a search of PubMed and EMBIS from January 1, 1992 through January 7, 2017. The search terms are as listed. Articles in adult humans were included. There were no language restrictions on the initial searches, and articles were included from any country. The exclusion criteria were as follows. Articles focused solely on children or articles that did not provide information on ages of included individuals. Articles that did not include data on Havrix or Vacta, the two single antigen hepatitis A vaccines currently licensed in the United States. Articles that only included safety data or discussed vaccine introduction without providing new data. Articles which only reported data on individuals with underlying conditions, and articles that only provided data greater than or equal to 28 days after the first dose of Hep A vaccine, as these data would not be applicable in an outbreak setting. This is a schematic diagram of the article retrieval process. Our search yielded 782 unique abstracts from PubMed and 257 unique abstracts from EMBIS. 936 articles were excluded because of relevance. The primary reasons for exclusion included that no adults greater than 40 or results of adults greater than 40 could not be separated out. No results for less than 28 days post-vaccination. Vaccines were used other than Havrix and Vacta. Animals were studied other than humans. The study related only to assay development. It could not be obtained in English. Only included safety data. Included only individuals with underlying conditions, or only discussed vaccine introduction. 103 full articles were reviewed and 95 were excluded. Reasons for exclusion included, again, that no adults greater than 40 or results of adults greater than 40 could not be separated out. The full article could not be obtained or could not be obtained in English. There are no results for less than 28 days post-vaccination. The studies only discussed vaccine introduction or other reasons. One additional article was originally missed because of misspecified mesh terms and was added, as was an article e-published in December 2016, but not added to PubMed until after our search was complete. The evidence types are shown here for reference. Grade of evidence for hepatitis A vaccines in persons aged greater than 40 years benefits will now be described. This table summarizes the characteristics of included studies for outcome 1, immunogenicity benefit. The columns represent the publication, author year, number of subjects, study design, ages, immunogenicity result, and seroconversion or GMT. The population age ranges varied. The correlate of protection or limit for seroconversion also varied. In some studies, it was greater than or equal to 10 milli-international units per mil, while in other studies, it was greater than or equal to 20 milli-international units per mil. Only 3 articles in the final review had direct comparisons between adults less than 40 years of age and adults greater than 40 years of age. BRIM, a retrospective cohort conducted in Iceland, Rumen, a retrospective cohort conducted in the US, and Van der Meren, a post-hoc retrospective pooled analysis from 3 randomized controlled trials conducted in Belgium, Finland, and Iceland. In the BRIM study, seroconversion at 15 days occurred in 77% of persons aged 40 to 62 years. In the Rumen study, which used half the recommended adult dose of Vacta, 25 units, 31% of adults greater than or equal to 40 years seroconverted at 2 weeks. In the Van der Meren study, seroconversion occurred in approximately 80% of adults greater than or equal to 40 years of age. 2 studies included adults greater than 40 years of age in the population, but did not present results differentiated by age. Golav was a multi-center controlled randomized open comparative study performed in the UK, Belgium, Germany, and France. Seroconversion occurred in this study in about 76% of adults aged 18 to 63 years. Bertino et al., an observational study conducted in the US, 46% of adults greater than or equal to 30 years seroconverted within 15 days. The only study to stratify by age groups greater than 40 years was Nelson et al. Reanalysis of Williams et al., which included adults with a mean age of 41 years. Seroconversion occurred in 74% of adults aged 40 to 49 years, 54% of adults aged 50 to 59 years, and 30% of adults aged greater than or equal to 60 years within 15 days. The grade of evidence for hepatitis A vaccines in persons aged greater than 40 years harms will now be described. Outcomes 1 through 4 include adverse events, hepatitis A infection, deaths, hospitalizations, and adverse events. Hepatitis A infection was described in 3 studies. Perron et al. Included adults greater than 40 years in Catalonia. Freeman et al. Included adults greater than or equal to 40 years in Australia. And Whelan et al. Included adults greater than or equal to 40 years in the Netherlands. Deaths, hospitalization, and adverse event outcomes were evaluated in these studies, and adverse events were evaluated in all studies. Four cases among adults greater than 40 years were identified in the 3 studies with information on hepatitis A infection. Of note, one of these cases occurred in a 43-year-old man, but no other information was provided. Incidence in the comparison group could not be assessed because no studies were identified that compared immunoglobulin and vaccine in adults greater than 40 years. Vaccine efficacy, absolute risk, and number needed to vaccinate also could not be evaluated in these studies. The evidence types are displayed here for your reference. These studies had several limitations. There were no randomized controlled trials identified comparing hepatitis A vaccine and immunoglobulin in healthy adults greater than 40 years of age. Only one study, a sub-analysis, contained immunogenicity data on discrete age ranges over age 40 years. No articles provided explicit estimates of the efficacy of hepatitis A vaccine in adults greater than 40 years of age against disease endpoints. And most studies included persons from outside of the US, including Europe, the UK, and Australia, though these populations may be similar to the population in the US. This is the grade summary. The benefit outcome immunogenicity was downgraded for inconsistency. Immunogenicity results in older adults showed high variability by study, with orders of magnitude differences in GMT results. Immunogenicity was also downgraded for indirectness. 4 of 6 studies did not provide results broken down by age group, included younger individuals, or did not provide details on age ranges. And immunogenicity was downgraded for imprecision. The studies included very few adults in the oldest age groups. Only one study provided results for adults greater than 60 years, and this included only 10 subjects. Hepatitis A incidence, death, and hospitalizations was downgraded for risk of bias. 2 of the 3 studies were surveillance studies with little information provided about the potential for missed follow-up. The overall evidence type for benefits and harms was 4. I would like to thank Dr. Ruth Link-Ellis and Dr. Megan Hofmeister for their contributions to the systematic review and the grade analysis.
I think we're going to go ahead and move on and come back to questions on all 3 presentations. Thank you.
Now I will discuss considerations for use of hepatitis A vaccines for post-exposure prophylaxis and international travel. The proposed updates to current 2007 hepatitis A vaccine recommendations for post-exposure prophylaxis and international travel include the following. Recommendations for post-exposure prophylaxis with immune globulin or hepatitis A vaccine for children aged less than 12 months and persons for whom vaccine is contraindicated, healthy persons, immune-compromised persons and persons with chronic liver disease, and pregnant women. Provider guidance on risk assessment and clinical decision-making for post-exposure prophylaxis is proposed to be included with updated recommendations. Specifically, this guidance would focus on exposure due to close personal contact, exposure in child care centers, exposure due to common source food exposure, exposure in settings providing services to children and adults, and exposure in natural disaster settings with flooding. Proposed recommendations for pre-exposure protection against hepatitis A for travelers would include specific recommendations by age group for infants aged less than 6 months, infants aged 6 to 11 months, healthy persons aged greater than 12 months, and immunocompromised persons and persons with chronic liver disease. The hepatitis A policy questions are as follows. For post-exposure prophylaxis, should hepatitis A vaccines be recommended for post-exposure prophylaxis for all persons aged greater than or equal to 12 months of age? Should IG be recommended at age 50 years in addition to vaccine? For international travel, should hepatitis A vaccines be administered to infants aged greater than or equal to 6 to 11 months of age pre-travel unless the infant is traveling to an area with no endemic measles transmission? Post-exposure prophylaxis and international travel. Should vaccine or vaccine with addition of immune globulin for post-exposure prophylaxis and vaccine for international travel be administered to pregnant women due to the risk of adverse fetal outcomes if the woman is infected with hepatitis A virus during pregnancy? Now I provide some hepatitis A background epidemiology and vaccine coverage. The number of reported hepatitis A cases declined substantially overall from 13,397 in 2000 to 1,390 cases in 2015. Within this time period, the number of reported cases increased from 2012 through 2013, and again from 2014 through 2015, primarily due to outbreaks. The overall decline is due to the success of hepatitis A vaccination, which was introduced incrementally in 1996, and universal childhood recommendation for children aged 12 to 23 months was recommended in 2006. From 2000 through 2015, rates of reported hepatitis A declined, except for a slight increase in 2012 and 2013 among all age groups except those aged 0 to 9 and 10 to 19 years. When comparing the 2015 hepatitis A rates of all age groups, persons aged 20 to 29 years had the highest rate at 0.6 cases per 100,000 population, and persons aged 0 to 9 years had the lowest rate at 0.1 cases per 100,000 population. The reported rate of acute hepatitis A for all children aged 0 to 19 is under the Healthy People 2020 target of 0.3 cases per 100,000 population. The hepatitis A vaccine coverage in 2016 is as follows. The greater than or equal to 2-dose coverage was 60.6% for children aged 19 to 35 months. This is likely underestimated since the first dose can be given up to age 23 months, with the second dose administered at least 6 months after the first. The greater than or equal to 1-dose coverage was 86.1% for children aged 19 to 35 months. The greater than or equal to 2-dose vaccine coverage for adolescents aged 13 to 17 years was 64.4%, while the coverage for adolescents with one dose coverage was 73.9%. The greater than equal to 2-dose vaccine coverage for adults was much lower, 95% for adults greater than equal to 19 years, 13.4% for adults 19 to 49 years, and 5.4% for adults greater than equal to 50 years. There have been multiple hepatitis A outbreaks over the last 5 years, including outbreaks related to contaminated food and person-to-person transmission. A multi-state outbreak associated with frozen pomegranate arils imported from Turkey occurred in 2013. In this outbreak, there were 165 confirmed cases. 42% of the cases were hospitalized, 2 cases developed fulminant hepatitis, and 1 case required a liver transplant. An outbreak associated with raw scallops on Oahu and Kauai, Hawaii occurred in 2016. In that outbreak, there were 292 confirmed cases and 74 hospitalizations. A multi-state outbreak linked to frozen strawberries in 2016 had 129 confirmed cases and 59 hospitalizations. Outbreaks of hepatitis A in multiple states among people who are homeless and people who use drugs have been ongoing since 2017. In California, the case count as of February 9, 2018 was 694 cases, 454 hospitalizations, and 21 deaths. In a separate outbreak in Michigan, the case count as of February 14, 2018 was 751, with 609 hospitalizations and 25 deaths. In Utah, linked to the California outbreak, the case count as of February 20th was 181, with 90 hospitalizations. Outbreaks in Kentucky and Missouri are also ongoing, with active investigation. The current recommendations for post-exposure prophylaxis and international travel were approved in 2007 and are as follows. Persons who recently have been exposed to hepatitis A virus and who previously have not received hepatitis A vaccine should be administered a single dose of single antigen hepatitis A vaccine or immune globulin as soon as possible. For healthy persons aged 12 months to 40 years, single antigen hepatitis A vaccine at the age-appropriate dose is preferred. For persons aged greater than 40 years, IG is preferred. Vaccine can be used if IG cannot be obtained. For children aged less than 12 months, immunocompromised persons, persons who have had chronic liver disease diagnosed, and persons for whom vaccine is contraindicated, IG should be used. For international travel, the recommendations state that all susceptible persons traveling or working in countries that have higher intermediate hepatitis A endemicity should be vaccinated or receive IG before departure. Hepatitis A vaccine at the age-appropriate dose is preferred to IG. The first dose of Hep A vaccine should be administered as soon as travel is considered. 1 dose of single antigen Hep A vaccine administered at any time before departure can provide adequate protection for most healthy persons. Older adults, immunocompromised persons, and persons with chronic liver disease or other chronic medical conditions planning to depart to an area in less than 2 weeks should receive the initial dose of vaccine and also simultaneously be administered IG at a separate anatomic injection site. And travelers who elect not to receive vaccine or age less than 12 months or are allergic to a vaccine component should receive a single dose of IG, which provides effective protection for actually up to 1 month. The evidence for the 2007 recommendations is based on a hepatitis A vaccine post-exposure trial conducted in Kazakhstan and published in 2007. In this study, 1,090 household or daycare contacts of 920 index cases were enrolled. The ages of enrolled persons range from 2 to 40 years of age. Enrolled persons were included if exposure to an index case occurred within 2 weeks after index case symptom onset. Enrolled persons were excluded from the study if there was a history of hepatitis A vaccine, or immunoglobulin in the previous 6 months. The study design was a randomized non-inferiority study comparing hepatitis A vaccine, VACTA, or immunoglobulin. The primary outcome was lab-confirmed symptomatic hepatitis A during 15 to 56 days post-exposure. The study found that hepatitis A vaccine efficacy was similar to that of IG. The study's pre-specified criterion for non-inferiority was met. In the per-protocol analyses, 25 primary endpoints were reached among vaccine recipients, or 4.4%, and 17 were reached among immunoglobulin recipients, or 3.3%, yielding a relative risk among vaccine recipients as compared with immunoglobulin recipients of 1.35, with a confidence interval of 0.7 to 2.67. Since the Victor study in 2007, few studies have evaluated hepatitis A vaccine response among adults greater than or equal to 40 years of age. No randomized controlled trials are available, and limited studies are available with data broken down in discrete age groups greater than 40 years. There are no direct comparisons between hepatitis A vaccine and IG available for older adults, and it is unlikely that additional post-exposure efficacy data would become available because of the difficulties of conducting post-exposure efficacy studies of IG and vaccine. The recommended dose of IG was increased in September 2017 from 0.02 milliliters per kilogram to 0.1 milliliter per kilogram. This change was made due to concerns about decreased hepatitis A virus immunoglobulin G antibody potency, likely resulting from decreasing prevalence of previous hepatitis A viral infection among plasma donors, leading to declining antibody to hepatitis A virus antibody levels in donor plasma. Challenges exist with the current post-exposure prophylaxis recommendations from 2007. In recent years, there has been an increase in hepatitis A outbreaks requiring post-exposure prophylaxis, as described earlier. State and local health departments report that timely receipt of intramuscular IG has been difficult since most providers and health departments do not routinely stock it. There is often a need for multiple injections of IG per dose, particularly for adult patients, due to the increased dosing to 0.1 milliliters per kilogram and subsequent increase in volume of the IG dose. This has resulted in challenges related to IG cost and administration. In recent outbreaks, state and local health departments have opted to administer hepatitis A vaccine, which confers long-term protection, to persons aged greater than 40 years for post-exposure prophylaxis. Now I will discuss the policy considerations regarding Hep A vaccine, post-exposure prophylaxis, and international travel. Should hepatitis A vaccines be recommended for post-exposure prophylaxis for all persons aged greater than or equal to 12 months? And should IG be recommended at age greater than 50 years in addition to vaccine? The work group considerations were as follows. Advantages of hepatitis A vaccine compared to immunoglobulin include induction of active immunity and longer protection, greater ease of administration compared to immunoglobulin, which has an increased need for multiple injections due to the increase in dose or volume of the IG dose. Hepatitis A is routinely available. It's available in the United States from only one manufacturer. IG is available in the United States from only one manufacturer. That's Grifols Therapeutics. IG is not routinely stocked by many providers and health departments, making timely administration of intramuscular IG challenging. Additionally, hepatitis A vaccine might cost less per dose, particularly when multiple injections of IG are needed. Using vaccine for post-exposure prophylaxis in persons aged greater than 40 years, brings the U.S. practice in line with other countries that provide post-exposure prophylaxis. In the U.S., some states suggest using vaccine for post-exposure prophylaxis in adults greater than 40 years. For example, the California Department of Public Health suggests consideration of Hep A vaccine for post-exposure prophylaxis in persons aged 41 to 59 years of age because it confers long-term immunity. The Michigan Department of Health and Human Services also suggests consideration of hepatitis A vaccine for PEP in persons 41 through 74 years of age if IG is in short supply. When indicated for use, IG should be given within 2 weeks of exposure. This was interim guidance for that ongoing outbreak. In addition to the literature review that was previously described in GRADE, we reviewed current hepatitis A post-exposure prophylaxis recommendations in other countries with the results shown here. Countries generally agree on use of vaccine for PEP in healthy adults 1 to 40 years of age. Likewise, there is general agreement that IG, with or without vaccine, is ideal for immunocompromised individuals and those with chronic liver disease. The US and Israel, however, the only two countries we identified which recommend IG alone in individuals over 40 years of age. Limited data suggests protection at 15 days post-vaccination for adults 40 to 49 years of age. Among adults aged 50 to 59 years, data suggests substantial protection by 30 days post-vaccination. These data are shown here and were partially described in the GRADE presentation. Seroconversion at 15 days for 40 to 49 years is 74%, 90% at 30 days. Seroconversion was 54% at 15 days for age 50 to 59 years, or 81% at 30 days. And seroconversion was 30% at 15 days for greater than or equal to 60 years, 50% at 30 days. Though the age ranges are not discrete, two studies that evaluated immunogenicity in adults greater than or equal to 40 years had a comparison group and are shown here. These were also presented in the GRADE. For the BRIM study, seroconversion was 77% for persons aged 40 to 62 years, compared to 90% for persons aged 20 to 29 years at 15 days. In the Van der Meuren study, seroconversion was 79.7% for persons aged greater than or equal to 40 years, and 92.3% for persons aged 20 to 30 years at 15 days. Another study with a comparison group, Ruman et al., included a lower dose of vaccine than is currently recommended, and therefore was not included on this slide. In the work group perspective, it is unlikely that additional post-exposure efficacy data will become available because of the difficulties of conducting post-exposure efficacy studies of IG and vaccine. Administering vaccine provides long-term protection and is beneficial for a substantial number of adult recipients, even in older ages, such as greater than 60 years. There are limited data and evidence of lower efficacy in older adults aged greater than 50 years at 15 days and aged greater than 60 years at 30 days. Have infection is more severe in these older age groups. IG, in addition to hepatitis vaccine, might be beneficial for persons in these age groups. Data are limited on vaccine or IG failures. However, reports of failures are rare. If IG or vaccine is not available, the available product should be administered as soon as possible. The person may return for the second product if available within 14 days of exposure. The summary of proposed recommendations for post-exposure prophylaxis are shown here. The specific changes discussed are outlined in red. Should hepatitis A vaccines be administered to infants aged greater than or equal to 6 to 11 months of age pre-travel, unless the infant is traveling to an area with no endemic measles transmission? Workgroup considerations. IG cannot be administered simultaneously with MMR vaccine, which is recommended for infants aged 6 to 11 months traveling internationally from the U.S. Administering hepatitis A vaccine in infants is off-label, and doses administered prior to age 12 months are considered invalid. Infants receiving hepatitis A vaccine would need to complete the full 2-dose Hep A vaccine series beginning at 12 months of age, or 6 months after the invalid dose to gain long-term immunity. Infants 6 to 11 months traveling in countries classified as having no endemic measles transmission, example in Western Hemisphere, but where hepatitis A may remain an intermediate or high endemicity, IG may be used. Routine administration of MMR vaccine may be delayed because it may be administered no earlier than 3 months after IG administration. The work group perspective is that due to the severity of measles in infancy compared to hepatitis A viral infection in infancy, MMR vaccine should be administered preferentially to immune globulin. Administration of hepatitis A vaccine, which would be off-label use, and MMR vaccine to infants aged 6 to 11 months would provide protection against hepatitis A virus and measles and allow for simultaneous administration. The summary of the proposed recommendations for international travel are shown here. The changes discussed are outlined in red. The next question, should vaccine or vaccine plus immune globulin be administered for pregnant women due to the risk of adverse fetal outcomes if the woman is infected with hepatitis A virus during pregnancy?